on your phone, and it's sponsored, EHHS.
Yeah, I got that, but
And then you click that and it asks to sign in and you say sign in.
it's not going to the sign in page.
It's being recorded, everyone.
Okay.
Sign in my app. I don't want to do that.
Technology.
I don't know.
I lost it a couple weeks ago. I carry water in my bag. The cap wasn't on my office. I should have been, it leaked in my computer. I was able to save the heart, give a heart transplant, which is the hard drive.
Okay.
I was thinking, it's like,
You did.
oh man, yeah, on my computer.
So,
So I now learned to back up external distance.
yeah.
Sharon.
Talk about dodging a bullet.
All right, here, you can go ahead and start.
All right, start.
Yeah.
Okay. It is now
9:46.
time back. 9/4/2024. As the chair, I will convene the prescription drug affordability board. My name is Gary Merchant. I'm a state rep currently, and I'll pass it on to my board chair, pass it on to my left.
Tom Herman, I'm an elevated alternate, and I guess I'm Cindy Rosenwald. So I'm a retired physician.
Yeah, Bob Woodward, also an elevated alternate, from, UNH.
Thank you. And on the Zoom, I think we had Abbas, I thought we saw Representative Edwards. Would you introduce yourselves, please?
Hello, Senator Darrell Abbas, District 22.
Thank you. We have Representative Edwards with us. Okay. At this point in time, I will officially elect it here, but also the fact that Senator Cindy Rosenwald's not here elevates Tom Sherman as a member. For today's meeting only, that will create the quorum. As far as the approval of October 28th minutes, I think we're going to delay those.
Yeah.
Is that correct? It'll be until next time. The board discussion, looks like it's your call there. Director.
Oh, by the way, this is Jess Edwards. I just figured out how to unmute myself.
Oh, good, okay,
All right, thank you.
good.
Technology.
Okay, so the annual report, we're able to get that over the finish line. Thank you all for all of your help, pulling all that together. One thing that was very clear was the need to turn, our information into recommendations or come up with recommendations, not for this year, but for the purposes of next year's report or in the course of your work. When you looked at the statute, kind of at the core of what you all were tasked with doing, RSA 126, do you guys need something?
No, we're just talking about.
Okay. RSA 126 BB5, it directs the FDAP to determine annual spending targets for specific prescription drugs that may cause affordability challenges. Within the statute and included in the report, we have the top prescription drugs and only dispensed with the greatest year-over-year cost increases. And those are, even though it's outlined in the statute, these are one way in which you can look at prescription drugs or have a more targeted list to steer your focus.
Kurt, could you minimize that?
Yeah, let's see if I can do that. Okay. So let me talk about healthcare spending targets very briefly. They began really in 2012, right below us in Massachusetts. They were the first state that began setting targets for annual growth rates, but particularly for healthcare costs. Since 2012, several other states have established statewide healthcare cost growth benchmarks. Importantly, none have done that for prescription drugs. Part of using healthcare spending targets, it requires consistent measurement of annual healthcare costs. That may vary by state, how they define healthcare costs. I'll include essentially payments by insurers for the cost of healthcare goods and services. The patients, so the out-of-pocket costs they may pay a doctor's visit, and the costs associated with administering the goals of spending targets usually includes preventing healthcare spending from growing faster than other services, bringing public purchasers together to help incentivize them to actively negotiate better deals, or garnering support among public payers for legislation that would directly lower prices. Again, this is usually done in the context of medical settings or medical care services. Hasn't been applied to prescription drugs, doesn't mean it can't be, just hasn't been. So for prescription drugs, when you're thinking about whether or how to set spending targets, it might be useful perhaps just setting target services just by payers, and that could also be benchmarked against healthcare services or non-healthcare services. There are specific challenges when you get to setting targets for prescription drugs. We've talked about a lot of these issues really at length, particularly around rebates, understanding the net price paid by public payers or by payers included in a spending target. Cost sharing, we read about it in the report and we've discussed it in many meetings. Manufacturers, they often will provide discounts or coupons that are not necessarily reflected in the amount that patients pay. They might be reflected in data from pharmacies rather than payers or within the APCD, but that would be a conversation. Pharmacies see how they collect, et cetera, et cetera. Provider administered drugs, clinician administered drugs, those drugs that are paid for under the medical benefit, that's a separate coverage and reimbursement policy. And those different benefit. And so trying to disentangle J codes and HCPCS and trying to identify those drugs that are maybe administered as part of a bundled service or within a healthcare setting. It's not readily available in claims, not that we can't do it, and we certainly will be looking at spending on medical benefit at some juncture, but they don't have the same sort of pricing distortions as retail prescription drugs with rebates. And so that's just another consideration.
You want questions as you go or questions at the end?
Why don't I go? Sure.
It seems to me this set of bullets in particular, it focuses on the challenges of the data sets as opposed to the challenges of what the targets are that we should be focusing on.
Sure.
And I would recommend separating those issues out. There are challenges. It's our data set mostly. There are challenges of the concept.
Yeah.
So for example, the slide before talked about costs. The word cost can mean the price per, we've been using a day's supply, versus the expenditure over all people.
Right.
And some of the growth in aggregate expenditures will be growth in the utilization of drugs as opposed to. And some of that utilization, for example, it can be for the FDA approved, and some of the utilization can be for the non-FDA approved use of that drug. As we set targets, I think we ought to have a conversation about what the concepts are that we should be focusing on, as opposed to what the data problems are with the limitations of data sets are. So for example, the pharmacy provide versus the medical benefit issues, that's entirely a data set issue.
Yeah. Oh, I totally understand. And I'll be getting into more of the conceptual challenges. But when you're looking, if you're going to look at, like you pointed, if you're looking at spending on the medical benefit or what the spending is in the pharmacy benefit, understanding the rebates and where what the net price is paid, I mean, that is a real challenge to measuring the growth. So I just want people to be cognizant of what it would take for us to appropriately and accurately set spending targets. And it's not like we can't get around it, right? These are data sets. And if we don't have the right rebates data, we will need to figure out how to do that.
Right.
But I'm just pointing out some of the specific challenges as we're trying to measure spending. And then there are the challenges, of course, with administering these benefits and how our payers supposed to appropriately separate out what administrative overhead was due to specific prescription drugs versus other healthcare services. As we keep going, another one is the calculation. So when we get into what it says in statute, these targets must be based on a 10-year rolling average based on the Consumer Price Index for medical services. Many states for their healthcare cost growth benchmarks have been around 3.1%, but again, this is around other healthcare goods and services, not necessarily prescription drugs. As a reminder, inflation is a measure of changes in price. It's not a measure of changes in spending. So spending could increase due to, exactly to your point, due to utilization, off-label, on-label, even if those prices for those drugs remain stable or decreased. Again, we would need to know WAC data and rebate data, but spending could increase for a variety of factors, not necessarily driven by the price. And then brand name and generic spending, that might need to be measured separately, particularly when you think back to how much you're spending on the top 25 costliest versus the top 25 most utilized. We may need a different targets for the brand name drugs. And then, of course, enforcement in states with healthcare spending targets. In order to help meet those targets, they have a variety of enforcement mechanisms. Some have none. They range to financial penalties, inviting in specific either hospital systems or provider offices to provide public testimony, and then structured performance improvement plans. And then it's great to provide the data to bring about transparency, but these spending targets would be much more effective if there were strong enforcement mechanisms. So as we continue going, another challenge is that if you were to set a spending target, we saw the challenges with HCV or hepatitis C antiviral drugs. Because you set a spending target, and if you're asking a public payer or any payer to meet that, it could mean access, which would not be the goal. We are trying to lower the price and increase access or improve affordable access. But you wouldn't want to set such a strong target without assisting the public payer in meeting that target. And we saw that with HCV when that was coming out, that many Medicaid programs, many states were highly restrictive. Yes.
So when the legislation says we should be setting spending targets.
Yeah.
What's the word spending refer to? The aggregate expenditures or the price that we're willing to pay for a.
That's a really good question. And it doesn't go into great detail in what?
Yeah, it's left open.
Yeah, it's left open to the board.
For my recommendation we would kind of try to clarify that
Yeah.
recommendation
anyway. I don't know whether the legislation needs to be changed.
Well, that paragraph is not optimal. That's, we have discussed here many times,
But
so it would be, I think it would be something that would be great
So I
to
had
change if
my
we can
hand
reach
up.
consensus.
Go ahead.
I had my hand up. I'm sorry, but since we're on the legislation, there are a couple of bills that are still in draft related to the PDAB. And the details have been worked out with Representative Merchant and Senator Rosenwald, and to a lesser extent, Dr. Sherman. If there is something that's in the statute now that you want clarified, send me specifically what you want it to read, and we got a perfect time to amend it now. So that window is closing. So if Dr. Woodard, if you want to stick your finger in the RSA where it says spending and you want it to say something smarter than that, just send me the specifics.
And this is exactly the type of discussion I was hoping we could have. And understand, and just because it doesn't define spending, doesn't mean we can't define it during rulemaking, but there could be ways in which we can improve the statute that can make this easier, and we can get into that. So I use the example of hepatitis C program. Many states instituted very restrictive utilization management criteria that curtailed the use of these very effective therapies, which was not the intent. But it does show the challenge of trying to manage public expenditures and high cost drugs.
Just to give that perspective.
Yeah.
When those I was in practice, and that's one of my organ systems. They were incredibly effective, 95% cure.
Yeah.
Or upwards of 90% cure. 90-day supply, that was the treatment, $1,000 a pill. So coming out of the gate, it was $90,000, and it would have broken the bank for Medicaid programs across the country if they hadn't restricted access. So we were all crying foul when they were restricting access, but
Right.
it was a huge challenge.
Same thing's going on now with GLP-1s.
Sure, yeah,
Right.
Exactly.
Obesity.
right. And again, with HCV, that really hit Medicaid programs. Many, it disproportionately hit Medicaid, and those are exclusively taxpayer dollars, whether federal or state. So I wanted to highlight that challenge. I'm gonna go ahead and minimize this. Sorry, Representative Edwards, just jump in if you have something else to say. I'm gonna need to minimize this. Okay, so in order to do this, go ahead.
I'm so sorry. I just need to talk technical stuff for a second. I'm not sure if you're aware of this, but I don't see anything that you may be presenting or sharing. The auditorium is not coming up. No presentations are coming up. So I didn't know if you were expecting that, but we're not seeing that. I'm certainly not.
Okay.
Sorry.
Can you see this?
I see your face. I think the issue might be that you're logged into both the auditorium computer and your laptop. I'm sorry to interrupt the meeting. I need you to know we don't see anything.
No, thank you.
It's a PowerPoint.
Okay, that's yikes.
I was sharing.
Kirk, are you actually logged in as you in the auditorium?
Mhm.
You might want to drop out your laptop. I think that's the issue.
I don't have that out.
You don't have your laptop on?
No, I can.
Oh, that I can see it now. That looks good.
You can see it now.
Measuring prescription drug spending?
Yeah.
Yes.
Yeah.
Yes. Yes, I
So
can.
whatever you did. Kirk,
Yeah.
I don't think.
Oh my God.
It's much better. Thank you.
You're at 10. Okay, so you can see this now? All right. Okay. Oh, it's so fun when you get your. Okay, let me get the flow back. All right, so in order to do this, we must be able to systematically measure annual per capita. That include, the cost by the state funded health plans. I named some of the data sources where this could come from. Retail prescription drug spending, we can get that from CHIS data. Administrative cost, best if we can get it from public payers, or if we're able, maybe just estimate it. Again, rebates, if we could get that directly from public payers, I just would remind everybody our ability to collect data from health plans, manufacturers, PBMs, wholesalers, and other third-party payers was suspended until next July under HB2. And then not only the cost by the state benefit plan, but also by beneficiary. So how much are they paying in premiums for their prescription drug coverage or medical coverage for those provider administered drugs, out of pocket costs, and then also if they use discounts from manufacturer coupons and patient assistance programs. Okay, so although other PDABs take a variety of different approaches to doing this, only Maine and New Hampshire's statute identifies setting spending targets. And then there are a number of recommendations that you all are able to recommend to help meet those targets. Other states have other approaches. So generally, they all start out with identifying a subset of eligible drugs. I think Colorado identified something like 600. We have in our report the top 25 costliest, most utilized, and greatest year-over-year cost increases. A lot of times, the legislation itself will specify how the PDAB is supposed to identify the eligible drugs, but that's usually just the largest pool of drugs you would start with. You would then use that list, and based on established criteria, you would select drugs to review their affordability. You would begin narrowing that list of, let's say, 600 drugs down to, I don't know, 20 or 10 or 5. And then you would all vote to perform an affordability review. And then upon each affordability review, you would decide whether or not that drug is affordable or unaffordable based on your definition. And then you would vote to either, some states have upper payment limits, other like ours have spending targets, or a totally different recommendation, or some blend of these approaches. But generally, this is how PDABs have structured their process for reviewing the affordability of drugs and then coming up with recommendations. I'm going to walk through a couple examples. This is Colorado's PDAB. This is how they have structured their process. Again, starting with identifying specific prescription drugs, and moving through the process to determine whether or not they're affordable or unaffordable. Establishing an upper payment limit, then that goes into a whole nother process. And Colorado right now is going through their rulemaking process around establishing UPL's upper payment limits. And in Colorado, that is across public and private payers. This is across the market. So all consumers benefit from this upper payment limit. But that's just illustrative of Colorado. Maryland is also pretty far along in their process. Again, it's roughly similar. They have a meeting where they discuss which prescription drugs would be included in the list of eligible drugs for cost reviews. There's also a public reporting aspect where the public can report whether or not they're having issues with specific prescription drugs. Go ahead.
What does Maryland use as the criteria when they select these? Is it cost?
Some of it is cost. I don't know Maryland specific ones. A lot of times they'll say a branded drug with a annual cost over $30,000 based on the wholesale acquisition cost
Per subscriber? Per user?
Per treatment, of course. So if the annual WAC price is above 30,000, the annual, like you mentioned, HCV $90,000, that drug would fall into an eligible list. Okay. There's also other, did it increase faster than inflation? That would be another criteria. Generics, it would be a lot lower of a threshold for their WAC price. Then they would have a subsequent meeting where they would take that list, identify the prescription drugs, and then they would refer those drugs to the stakeholder council for their input. The stakeholder council then reviews and they'll discuss it. An open meeting. And during all of that, there are opportunities for public comment, listening sessions with affected stakeholders, consumers, patients, others, and then the board would select which drugs to go into cost reviews, which is another lengthy process of determining the affordability, where they collect a wide range of data from payers, manufacturers, PBMs, their ABCD. They analyze the cost of the system, and then the staff will make a recommendation to the board. The board would then deliberate and ultimately vote on next steps. And then there's the New York Medicaid drug cap, which is not necessarily what PDABs do or have done, but it is similar in concept, and this may be more amenable to how our legislation is laid out in statute. But I would remind everybody, Medicaid, they have statutory rebates, basic rebates. It's much different. They're able to, and New York's volume is quite large. But it's similar in process. They have a budget cap. And then they set a projected budget cap. And if certain drugs are deemed to blow past that cap, they separate it to brands and generics. They assess to see whether or not that spend would exceed the cap. And if yes, it goes through a structured process. And if no, it falls out. And this might be another way of saying, you know, above, let's just throw a number out there, above two, if we all spending on prescription drugs is, you know, going to exceed $300 million in a given year. And, you know, all of a sudden it went 50 million above. Okay, so what drugs contributed to that $50 million excess? And then you would work your way backwards and say, okay, well, how effective are these drugs? How do they stack up to therapeutic competitors? And, you know, what should be the negotiated price for Medicaid? It's what would be the target supplemental rebate? For other states, it could be what is a upper payment limit or spending target. And so, you know, there are some considerations, again, when you're thinking about setting spending targets and how we want to organize ourselves and determining a process or establishing a process. This is a lot of system engineering. This is a change in how we are examining prescription drugs and how the state will determine how they are willing to pay for those drugs. There are financial and operational resource concerns for how we are able to get this off the ground. The feasibility and practicality of any given approach, the data that we may need that we have or do not have. You know, how stakeholders perceive this work and how we are able to incorporate patient experience into this process. And then, you know, what would have the most impact? Are we just looking to broadcast what we're doing and bring more transparency? Are we looking to actually lower spend? Those are all decision points you all will need to make.
When you use the word stakeholder, are you talking about our advisory
That
council?
too, stakeholder perspectives, but I would also say industry, PBMs, insurers, the carriers, who each, so Health Trust, who are their PBM, public employee plan, you know, we would want to bring all these folks in the process and see how they are perceiving or would be able to implement this work. And so, you know, we wanted to have a discussion about how we get this off the ground. This is a big task. How do you want to organize yourself over the next calendar year? You know, what else would you like to learn when you're going about setting spending targets? And is this the preferred approach? You know, to Dr. Sherman's point, you know, the paragraph around this is a little bit murky. Is this the preferred approach that you all want to take? And then what partners and resources will we need to bring to the table to ensure our success? And how do we want to define our success and measure it in 2025? You all want to set spending targets come November? And is that how we want to measure our success? Is it just exploring and piloting a process? Is it just coming up with a process that we can all get around? I think those are all open questions. So I'll leave it to you all to begin discussing, you know, how should we start organizing around this work? I'm going to stop sharing your screen so that we can see Jess Edwards and Senator Abbas. Go ahead. Yeah.
This is something that came up after the last election, and I just wanted to reiterate it. This is not a legislative committee. It's great that there are legislators on it, but it was never intended as a board to be staffed with only legislators. So the intention was to get people with appropriate expertise to work on this. The oversight, as we've talked about before, is not just the legislators on board, but also HHS Oversight Committee. But the reason I say that is because one of the things that's been fairly clear to me is that meeting once a month and staying public, which we're required to do, and only meeting once a month, it's gonna take us about 20 years to do this.
That's the problem.
I think we need to think about either forming subcommittees that can take on some of this work, they still have to stay public, or increasing the frequency. There's only 5 board members at this point, that and alternates. So whether that would mean increasing the frequency of the meetings so that we can actually tackle all this work that you're talking about, I think that may be something we need to do. Somehow structuring ourselves so that we could, this is going to take hours of work. And to really even just figure out how to move forward. But to Representative Edwards' concerns expressed as we were discussing the annual report, we need to get going. We need to start coming out with recommendations, but you've outlined the process to getting there in other states, and that's labor intensive. And so my point is, I think we need to think about how, as a board, we can move forward, and whether that's with subcommittees or more frequent meetings with whatever quorum can be there to get that done is the big question.
I think as well said. The only time we really have to focus on a quorum is if we take an official policy vote on something. So we could, in essence, have a subcommittee meetings or something of that nature and not be concerned about the quorum, because unless we're actually making a vote on something, it's not required to have per se a quorum. So we have a work group, if you will, at that point in time. But they should be public. I think one of the things we have to talk about is we're talking about transparency in the industry. We have to be as transparent ourselves at the same time. And you can't sit here and say,
Right.
you have to be transparent, but we can't. And I think that's one of the things. So I would look at the structure going forward. I do agree with you, Dr. Sherman, that we have to have more time put into it. And either one works better. I think the frequency may help. And again, back to the same thing, it doesn't require a quorum per se, but it does require us to roll up our sleeves to get the work done. Right. I can go.
We do, and we do have a line item for contracts and program services. So we can issue an RFI to try to get a partner or consultant that can help us with a lot of this work, which is needed if we're not going to be bringing on additional staff. And our budget is very slim. So, it is, I would just also note that under HB2, all of our contracts also have to be reviewed by the fiscal committee, which is unique from all other boards in the state. So that's just another time delay, but again, it would need to go to the fiscal committee and the executive council, but it would be great if we could bring on a consultant or another partner to help with a lot of this work, because as you said, it's going to take hours and days and a lot of more expertise than we, I think, currently have. But
Would you ask Rob Berry or somebody else if we're having a work group and we fall upon, again, the quorum, since it's not an official meeting per se to vote on something, can we do it via Zoom? Versus, because again, travel time and trying to be cognitive of people's time, we could use the time more efficiently without running across the issue of creating a quorum, then when it's just going to be a work group and not really having us make decisions on policy, on rules and so forth. I think we may have some latitude, but it helped to have somebody understand that.
Whether it has to be on SharePoint as opposed to Zoom. So the state has gone to the Microsoft SharePoint, which is not Zoom. We just need to clarify whether we can use Zoom or whether you have to.
Well, I think what you're asking is remote versus.
I understand that.
So whatever vehicle.
Yeah.
Given that the state is mandating.
Right, so we probably have to use the state if we are going to meet.
That's what I'm pointing at.
Yes.
If we're going to meet the transparency and have it public, it's gonna have to be.
And if we do it via Zoom, what I'm thinking about at the same time is
You
that
mean remote?
remote.
John is on this.
if we meet remotely, then it does open up the possibility, and with the connections that Mr. Williamson has, is bringing in subject matter experts that can possibly help us.
Yeah.
Yeah.
Instead of us having to reinvent the wheel ourselves, become subject matter experts, we can bring them to us collectively through that process.
Right, right. And we have the benefit of other PDATs having gone before us and developing a lot of these rules and regulations, and we have a lot to learn from. But it would be nice to bring on additional subject matter expertise. And just a reminder that it takes time to get to procure those services, but that's one option. Which I think is, it doesn't matter if you just decide to meet more frequently or not, we can still bring on additional expertise. I would just remind you that if we do subcommittees, we would still need to abide by 91A and the meeting notices and getting all of the information out in time, which is, weeks before. So it is a time and operational burden to do that.
What I'm wondering is, it's clear we need more time to
Yeah.
get this done, and
Yeah.
maybe Kirk, if you go and map out what you think it's going to take to get moving forward, one is a consultant, but two is what does the PDAB itself have to do?
Mhm.
And then we know better how
Yeah.
much time we're gonna need. I think that would be really helpful
Mhm.
looking towards 2025
Mhm.
and the time commitment that board members are going to need to put in,
Mhm.
especially the legislative board members, because
That's between the 1st of January through the 1st of July, because for them, it's difficult.
So clarification to a non-legislative. I don't know what's going on. So if we have a work group, a subcommittee of some sense, we need to use SharePoint. We need to have all the SharePoint, work group, meetings open to the public
Yes.
has to be publicly noticed with a certain.
with a weekend
What is
advance,
the statutory requirement for us?
A week before for us.
A week before,
with the agenda and the,
and how to get on.
Discuss, yeah.
that's still, that's still a lag and.
Right,
we
but
can
if-
get going
if-
beforehand.
Yeah, but if Kirk has a notion of what he's going to need to make this work, then he can map out the next 6 months.
Mhm.
And we can all update our calendars to meet that.
And then there's also the Stakeholder Advisory Council, which is
Right.
established to help you all do a lot of this work. Not that they are supposed to be doing it for you, but as we progress to bounce ideas off of them as well. So remember, they're a resource, and we also will need to schedule meetings for them as well, whether or not those occur in the same month or different months. But we can also outline that as well.
So that's a question, can any of us talk to any of the stakeholders outside of SharePoint?
Sure. You talking about doing as a person one-on-one with somebody?
Yes.
Absolutely.
That doesn't meet 91A. I mean, that doesn't violate 91A.
Right.
We could actually have two board members.
I could talk to you
Right.
Outside of,
outside of
Right.
this.
As long as it's a one-to-one relationship, not one-to-many.
right. Thank you.
So we could have a work group, Bob, in the same thing is that we focus on, say, which your background would be very helpful is in the data collection, data elements. Because that's your forte, along being an economist.
I would say small technical modification.
Small
to
T
that
versus big T,
is not,
okay.
is the analysis of data.
However,
I've never asked anybody any question.
However, one of the other things to look at is looking again back to the expertise we have on the board.
Yeah.
Is looking at Dr. Sherman, and one of the things I look for, there's three components to drug cost, globally speaking. What drug gets prescribed, the cost of that drug, and the use of that drug. And part of it is, when you think about recommendations, we talk about this again with biosimilars, is how do we work with the prescriber community to help them drive costs down? So is it back to, do we have a process, we go out and do academic detailing? We talk report cards. I don't know where to go, but we need to start thinking about the power of the pen has a tremendous amount to it. And then at that point in time, then you get into the cost of the drug itself, which goes back to the rebate issue is what's the net cost of that drug? And then you go back to utilization.
Mhm.
So when it goes back to those are the three components I'm looking at is they all drive overall drug costs. But how do we somehow maybe work with yourself and the medical society and come up with the issue of prescribing?
Well, we just had the meeting this past weekend. Our annual conference was this weekend.
Mhm.
And I know that they are more than willing to work with us to do that, so.
But I think the idea of having subcommittees based upon maybe a different one, working on, if you will, the data and then collecting the data we need. One's looking at maybe prescribers, looking at utilization. To me, it's not having a subcommittee, but maybe have multiple subcommittees that are working on different components in a parallel for sequential.
Mhm. I would say one consideration is like a lot of different people going in different directions. So we do want everybody to be on the same page. And one thing I worry about if we have a bunch of different subgroups is that people are gaining expertise and like kind of furthering the tribalism rather than you all coming together and having a deliberate discussion and moving forward as a unit. But whether that's just one consideration, I would say, but I don't know if we can get around not having subcommittees, but.
So again, details. If Dr. Sherman and I meet person to person and we ask you to monitor it,
Mhm.
that make it a committee and required openness?
No, if it's only you and Dr. Sherman with Mr. Williamson, there's no issue. Because there's no harm.
Right, that's what I'm asking you.
The same thing if you and Dr. Aziz met with Kirk, Mr. Williamson, no issue.
No issue. Right, got it.
And then I would also remind everybody that we also had goals that we identified in the annual report. So trying to do that work alongside this big process of either establishing a spending target or ways in which you will assess the affordability of this specific prescription drug that also will need to happen alongside.
I think the way to avoid chaos and anarchy.
Yeah.
Maybe to have at our next meeting, maybe our first meeting in
Mhm.
2025, have us, if we do form subgroups or subcommittees, give them very specific tasks and a deadline and have them bring back their answers, what they found out
Mhm.
to the full committee, to the full board at the next meeting. And that way, three things are accomplished. It's being directed by the board with everybody having input and knowledge. There's a timeline, so it's happening in a timely fashion and it's being brought back to the board to keep us all on the same page.
Yeah.
And I see your role as the director, so critical for this is when I think about all the different subcommittees. As long as it's only two board members there, we don't have an issue with a quorum. And tripping over that with 91A. And that can be done without it being official. You could meet, if you will, at that point in time and discuss what you want to discuss. What I'm trying to get to is that with Mr. Williamson being sort of the person within those two, he becomes the conduit for all of them,
Exactly.
you know.
I do want to go back to the 91A issue and us meeting, and I still think if these meetings are something that we're scheduling, it would be best if they were publicly noticed and people had, especially stakeholders had the opportunity to weigh in and participate. Because, one of the things that we've all learned when we've been in the legislature is how critical the expertise of the stakeholders is, so we don't go the wrong direction. You guys can keep us in line, so.
But one of the things also looking at going forward is the frequency. Again, we talk about trying to create, I think, more subcommittee structure versus going more frequent with the board. Is that kind of what I'm hearing? That'll
I
leave.
think more will get done.
I think I agree. And parcel it out.
Mhm.
If this is a work group, if you will. And
Can we get, Representative Edwards when
where's the Daryl?
Senator Abbas,
Where are they?
They're on
see if they
JE.
have thoughts? There's JE and DA.
DA and J.
One of the things that I tried to do with Mr. Williamson since the previous meeting was to sit down with him and see if we could hammer out a year-long plan on what we're going to try to do to get ourselves ready to publish the next annual report. And I think as we talked through that, it became obvious what we're talking about now, that it's very hard for us to move quickly because of the 91A issues with getting people together to meet and talk and do grunt work. But we need a lot of grunt work done, and it's hard to get organized for a public meeting to do that. So if we were able to do the grunt work and then review everything that was done and take a vote on it in a subsequent meeting, I would think we would be working towards 91A compliance, at least by intent, if not by statute. And so I just think we need to be more creative about allowing grunt work committee meetings to take place without triggering the full public disclosure, because it's slowing this down.
Sounds like it would be legal to do what we're,
Yeah, Representative Edwards, I concur. I think one of the things is when you get into a work group, what we need to be careful of is that when you look at board members and the composition of that work group with number of board members on the work group, if it's only two or less of us, then we don't trigger the quorum issues that have to then trigger 91A. But I'm looking at the work group more like you've got a couple of people on the board, but bringing in stakeholders in the stakeholder community and talking about, what is it? They're acting as a liaison between the board and the stakeholder community to try to understand the subject matter and how we can use that expertise outside of the board to your point, make the board more productive and get back to the annual meeting and the annual report.
Are you willing to take public comment?
I just, I'm on my town select board, so I deal with 91A issues a lot.
Yeah.
So I'm looking at guidance right now. So communications outside a meeting, including but not limited to sequential communications among members. So trying to do like front work off to the side actually goes against the spirit and intent of 91A. So I would be careful or seek, I think maybe legal guidance before trying to do sort of side subgroups that then come back.
unless those subgroups are publicly disclosed and.
Right, and follow the
Follow
requirements of
91A.
91A,
Right.
yeah.
Does that require then, which is fine, does that require minutes and everything else as well?
If it's a meeting, it has to have minutes.
Right. We've done publicly disclosed work groups in other commissions and councils without keeping formal minutes. But I mean, we're going to want to keep documentation
Yeah,
anyway,
right.
because we have to bring it
Right.
back to the full group. I don't see 91A as a big hurdle. I mean, being compliant with it, that's a big hurdle, and I think that's the spirit of all of this anyway, so. I mean, if it's just an informational phone call between me and Bob, that's not a big issue, but if it's gonna be a working group, I think the more the merrier.
Well, I think these are really good considerations, and we don't have to make this decision today. I think the purpose is to start discussing how we want to operationalize this, and I think I can talk with our point person in AG's office and Rob Berry to see how we stay in compliance. But then also bring this back in January after I've like distilled what I've heard, and you all can weigh how you want to do this.
Sounds good.
I'm trying to think of with this subcommittee, then also be cognitive of the fact of the resource being
Mhm.
yourself,
Right.
is how much.
And
that
Nancy.
And Nancy, and how much we're gonna need for resources in order to accomplish this. I don't disagree with the subcommittee work, which makes sense. But if we make it formal, which has its merits for sure, and also we've heard from 91A and people using it, then we have to have the personnel to help support the subcommittee work. And I don't know when we have that personnel.
I mean, I don't know. It does seem like a lot of work.
One thing that I really wanted,
Yeah.
maybe you can ask the AG, is there a difference between a working group and a subcommittee? When we had subcommittees of any prior committee, those all had to meet 91A.
Mhm.
So it doesn't matter what you call it. If it's a working group, is that less formal and therefore can have less structure? But I also don't think necessarily that PERG has to be there at every one of the meetings. Um, Unless he wants to. I think we can do a lot of the work
Mhm.
and just keep notes.
If it's, if it's remote, it's a lot easier. If it's in person, right, there's like scheduling the room and getting the Teams meeting. I mean, there are those administrative aspects.
I think if you can find out those answers
Yeah.
for January, that would be.
Yeah.
Because that's a really good point. If it's a work group, then I think we can, it's sort of an ad hoc. Then I think remote meeting would work. If it's a subcommittee and a formal subcommittee, then we have to worry about the quorum.
And there may be requirements for appointments to the subcommittee
Right.
and all that kind of stuff, as opposed to having it be a little more informal. With all interested parties or whatever, as long as we keep it to two.
So you'll follow up with.
Yes, yeah.
Actually, can I modify, and if you could let us know what the answers are, I don't think we need to wait till January.
Yeah.
To start hashing some of these things out.
Well, we can't have full conversations though. Over
Yeah,
email.
but
I can let you all know, but we
Yes.
can't have a dialogue about.
But we can
operational
respond
data.
to
You
you.
can respond to me only.
yeah, but what I was asking was, you're being asked to tell us what the ground rules are.
Right.
Do we need to wait till January to get those ground rules specified?
No.
So I would like to know what those ground rules are, so I can write them.
Yeah.
Good point. Minor, but critical.
Cool.
Yeah, if I can interject for a moment.
Yeah, Then I-
So I couldn't figure out how to raise my hand on this device, so. If, it seems the consensus is that there's a lot of work to be done, but not enough light in the day to do it. Is there any suggestion on legislation to perhaps expand the size of the board? Rather than have all these subcommittees and figuring out the 91A? I mean, if you had more members of the board, perhaps it would help alleviate some of that problem.
Well, I mean, it would help more staff for sure.
Yeah.
Maybe not no more board members that.
yeah. Senator Abbott, you raised a good point about trying to find additional human resources to help out in the cause, which I don't disagree with. But I'm also looking at it, whether the people who are on boards and haven't been on a few boards myself, board members don't always have the time to roll up the sleeves like employed staff has, or people bring it in as consultants. So I'm just concerned that if we expand the board, it's fine, but will that give us the actual labor we need to get the work done?
Also, we do have alternates like us so there's total 10, 11. Yeah, so even though we're not actual board members, there's nothing stopping us from being available. I worry about getting too big and unwieldy.
So Senator Abbas, I mean, one of the things to think about is that, is there any way you can envision maybe of additional resources that can be given to the board to help get through the logjam?
Well, in my experience in government, throwing money at a problem doesn't always solve it. It looks like an easy solution, but my thought is, why don't we try expanding the board by a few members? You know, I'm not talking anything drastic. Could be 3, could be 4 members. You know, we can discuss that. I think that would have a less fiscal impact, but will that work? I'm not guaranteeing it, but
If I could
this-
put on my,
thi-
if I could put on my Division 3 hat for a moment, this is not a particularly good budget cycle to try to be expanding uh, the resources for this effort. Uh, This is a very tight, constrained budget environment. I think that's publicly understood. So in that light, one of the things that has been worked on in background is the establishment of an account so that we could receive external gifts to help fund the work of the PDAB. I'm curious where we're at with getting that fund established so that we could start to solicit some contributions.
Yeah, that's one of the goals that we're looking towards for next year, and I've engaged our administrative liaison for establishing those rules and regulations, but I'm still waiting to get a first draft from them.
So
I
in
just
other
want to
words,
respond.
it's not gonna, in other words, it's not gonna be part of the budget in the next cycle?
Right, right.
Part of, I think, President Edwards running into, to your point, it's a tight fiscal year.
Mhm.
It just takes human resources to draft the rules and work through the process. Also with GelCar, and again, what we're facing is the fact that we are lacking some of the human capital that we need in order to get things accomplished.
Could we?
I offered an idea where there could be more human capital without the fiscal constraint, but
Well, if I could respond, Senator Abbas, you're talking about a high level of expertise. So I would recommend that we back up one before we're talking about funding and human capital and spend the time between now and January figuring out exactly what resources we need rather than I don't think there's anybody at this table who wants to throw taxpayer money. I mean, the whole point of this exercise is to save taxpayer money. So I do take exception that if you have a specific need that you need a specific expertise for, that's not throwing away money, but it also may be something with what Representative Edwards was saying, that we can find an alternative source for those a resource that is either available at no cost or minimal cost, but expanding the board and making us less efficient as a board. I'm not even a board member, I'm an alternate. And I'm willing to put as much time as needed with my expert background as a practicing physician, and Bob is too, to do this. So if we were to expand the board and have people with no expertise, we would actually make ourselves less efficient and less useful. So I would recommend that we take a step back and figure out exactly what our needs are to accomplish the goals that have been outlined today, both from an expertise level and whether that can be filled by current board members or whether we need additional expertise, and how can we do that at the lowest possible expense, especially in a tight fiscal year, as Representative Edwards said.
Senator Abbas, I see up there looking.
no, I'm sorry that you take exception to it. I'm just pointing out that because of the tight fiscal budget, that might be an option. And I would assume that any appointments that were made, whether it's the Senate President or Speaker of the House, they would be mindful of appointing someone with some experience in the medical field or the pharmaceutical field. There are elected members of both bodies with that experience. So, I mean, I don't think they're just gonna put
But
anyone on
they,
there.
but they don't have to be, right, they don't have to be elected members, and that's something that we keep running into.
Yeah.
We can get people from the community who are true experts, not members of the legislature. They have a lot of time,
Well, they have day jobs too.
and some of them do, but some of them don't, like some of us. And so, but I think before we talk about expanding the board, we really need to know exactly what we're dealing with in terms of need.
Mhm.
I think that's a good, Senator Abbas, I think when we get to reconvene in January, we'll have a better feel of what we're trying to accomplish as far as the subcommittees and the work groups and so forth, try to get some legal expertise to help us guide us, what's a work group versus a subcommittee, so we don't run afoul of 91A. I think at this point in time, even though having additional resources, which is your proposal, has some merits to it, I think it could be premature because we don't know exactly what we're trying to accomplish. Totally. So that's my thoughts on it. But back to the schedule, if I could, on 2025, right now, board meetings, not subcommittee,
Yeah.
but board meetings are still gonna be on the fourth
Mhm.
Monday,
Right,
right? At 9:30?
yes.
Now, that's the other thing, which I wanted to ask. We meet now for about 2 hours. Should we expand it on that day and make it a longer day? Or meet it, say, a time view? You know, we only have 2 hours, which is restrictive in its own right. So if we have a lot of discussion and so forth, it's hard to get through the discussion within 120 minutes.
About 9 to noon,
I'm just thinking about, yeah, 9 to noon or something like that.
it's fine with me.
A lot of the work.
Yep. I put it in 9 to 2.
Well, we also have the issue of, like setting these rooms up and everything. I mean, and when people actually get here.
Can you look, there's a couple of things we talked about. Representative Edwards, you talked about that before, is finding a room that's more conducive to meeting. Upstairs with 468 is kind of problematic because people have to get up to the security and so forth. There's some place either in the insurance department, I don't know, with, Consumer Advocate. If you have a room over there, we could utilize somewhere. It doesn't have to be here. It could be anywhere, as long as we have access to the technology.
I don't have a suggestion other than to say the LOB could maybe be asked to set us up, but,
That's good.
I just worry about it becoming
Yeah.
like, that we would then be viewed as a legislative
Yeah.
committee
Yeah.
if we were to meet in LA.
And then also during the sessions, it gets difficult to find rooms. I thank you for the offer. It makes sense, but I think we run into staffing issues with availability of rooms. But the insurance department has possibilities. I know we work with Central Prentice with some other places throughout the state agencies.
Why don't we let Kirk work
Yeah.
on it and
Yeah.
we've
Find a
got
place.
2 months.
Yeah,
Yep.
yeah.
All right,
Okay.
then we'll go from 9 to noon.
Or 9:30, could we do 9:30 and 12:30?
I'm okay with that. Is everybody else okay with that?
What is it?
9:30 to 12:30?
Yeah, that's fine.
That work?
Yes.
And then for this existing budget, again, we have money for contract expert services. So I would like to start on that process if we could. And then we have submitted our budget and it's pretty much the same amount of funding as Representative Edwards and Senator Abbas noted. It's a tight fiscal year. We, are putting in a prioritized ask for additional contract support, but I don't know if we'll get that this year, but hopefully if we can keep at least some money for expert services, we can have some more additional expertise. In the meantime, if we can't get extra human capital. So.
Well, if you could ask, I don't know if it goes back to, Nathan White, but in the budget, could we contract with a employment agency to help out with the times you have meetings? I mean, it's nice to have it internally, but,
10 agency or
somebody that has,
employment?
yeah. Can you do that, or somebody just trying to think of a way to,
I think we can, well, I mean, I think we can keep our own notes and
Keep our
then
notes,
turn
okay.
them into minutes.
All right.
If it's just a handful of them.
one of the things also, you could I don't know whether Share has it or not. I know Zoom does, but there is recorded meetings, but you get a transcript because
The HHS doesn't allow for the meeting that's being filed, so we can't use like AI features or transcription.
But there's no transcription on SharePoint?
There might
That's
be
what-
now.
Yeah.
Oh.
Actually, I think, Nancy, aren't you able to get a transcribed version of this now? I mean, it's not, it doesn't summarize it. It's. literally
Hi,
words
yeah,
together.
SharePoint's the wrong term to be using. The term is Teams. Teams is what we're using to, for these meetings. There is a transcription and it is, faulty at best. It does not accurately capture, dialogue very well.
Are we able to record?
Everything has been recorded since day one.
So that's,
So, Nancy, on the transcription, even though it's clunky and not ideal, is there enough bones to it that would help somebody draft the minutes? You know,
No.
sort of edit it, clean it up.
No, it doesn't,
Oh.
honestly, like 50% of the time, it doesn't even capture words correctly. It's awful. Sorry. I wish.
yeah, I bet.
All right. So at this point in time, you're working with, President Edwards on the budget? Or we
Well,
need to have a meeting with,
no,
about the budget looking
I
forward?
don't think so.
Okay,
No, I don't think so.
so we're just gonna hold what we have. Proposal going into fiscal
Mhm.
is gonna be basically what we have today.
Yes,
Okay.
yeah. Mhm.
It makes it
There's a
simple.
small increase to contract program services, but
Okay, like
that's it.
ICER and things of that nature
Right,
and so forth.
right. Okay. Any other questions about
No.
getting towards making recommendations, organizing ourselves? Okay. So for the next meeting, I'll look into the ground rules, try to get you that earlier than January. Try to sketch out conceptually, some of it is gonna be something, I'll have to make assumptions on like how we're going to do this and then work backwards for the time commitment you all will have to provide or need to provide in the meantime. Think through the work groups, maybe that's something we talk about the next meeting. And then look into the 2025 schedule, whether that's here or at the insurance department or somewhere else. Okay. And then, I don't think I need to switch to that. Okay, so I think we'll go into the annual report. Last meeting, it was discussed maybe adding an addendum if there's anything else people wanted to add. We just wanted to circle back to that.
I'll just make a comment. It was nice to see a report as thorough and as comprehensive that I've ever seen of this board. It was factual, had a lot of good content. I just want to say my hat goes off to you, Mr. Williamson, for creating and drafting such a document. It really speaks volumes to this board. So thank you.
Thank you. Thank you, Nancy. Okay, we'll move on to public comments then. Anybody?
Chime in.
Yes,
You want me to go there or sit here?
you can stay there.
Okay. Sam Palmeyer with PCMA, which
Yeah.
is the Trade Association for Pharmacy Benefit Managers. I do want to thank the PDEP for putting out this report, but we also do have some comments or concerns. And is there going to be an opportunity to provide those comments
Right now.
right now? I mean, I have a list. But if it makes more sense to do like a formal letter.
Yeah,
You want
that
to
would be,
submit?
that would be the.
Probably
I think it'd be better to have a formal letter to the board.
Okay,
So we have it at that point in time, well, we can capture what points out to being made. And it can become part of the record keeping we have.
and that would that be part of the addendum of the report added to it?
No, it would be your public response to the report that would go in the permanent record.
Yeah.
Okay,
They go on the website, it'll be there.
You don't have access to being in the report.
right.
But you have it, but your comments, public comments, like anything, you have the ability to submit it to the board and for the board at that point in time to then archive it. So it becomes a permanent document within the board itself.
Okay.
It could be on the website.
When does that do by?
yesterday.
No, whenever you want.
Whenever you want.
Okay.
Sooner the better, but you don't have no deadline.
Then I will save my specific comments for later.
Can I,
Sure.
you actually, every meeting, you have the ability to do public comment. So before the next meeting, you submit your letter.
Okay.
And then say, I'd
And then I
like
can walk
to
through.
walk through my letter.
Sure.
That would be hugely helpful.
Okay.
I think. And then it would also be doubly in the public record, because the letter plus your verbal commentary.
I will do that.
And then at that point in time, it'd be submitted to the board. Part of, again, back to the documents, we review it backwards, they become public.
Right.
At the same time.
And one last thing, when we're splitting up into these small groups, if your association, if one of them really fits one of these groups, we would love to have your expertise at the table.
Absolutely, yeah.
No, I think, at least myself, in working with stakeholder communities, it's the diversity of the stakeholder community and the subject matter knowledge that they bring to it, it makes it so more robust.
Sure.
And I'm a firm believer that if you pull together the stakeholder community on the front end, you start discussing the various viewpoints, the collective knowledge shared becomes very instrumental in trying to make something work going forward.
Appreciate it.
Oh, don't.
Hi, everybody. I hope you don't mind if I stand up.
No.
My name is Donald Crease. I am a voter and taxpayer residing here in Concord. I'm also a state employee, and I am here today as a representative of the public that the Prescription Drug Affordability Board serves, particularly state employees who appreciate the fact that we have prescription drug benefits available to ourselves and our families that are affordable and comprehensive and sustainable. I also, you might remember, because I was here talking to you all with my daughter a few months ago, that I am somebody who raised to a successful adulthood a young woman, almost 23 years old, who lives with cystic fibrosis. And what I have learned, or what I can say about that, is that her annual pharmacy bill is every single year she has been alive, a multiple of the annual salary that the state of New Hampshire pays me. I consider that to be an unsustainable set of circumstances. So unlike the folks on the other side of the room, I'm really here representing the people who really are the ultimate constituency of the Prescription Drug Affordability Board, the people who need drugs to be affordable. I'm also a member of the New England Comparative Effectiveness Public Advisory Council of ICER. And in fact, we just had a retreat and a meeting last week. So I'm kind of up to my neck in ICER. And I'm very pleased and excited to hear that there is a potentially or a nascent relationship between our PDAB and ICER. I really think I've been out in the working world for about 40 years now. I've served on boards and committees and various things like that. There is no nonprofit organization I have ever encountered in any sector that is doing better work than ICER is. It really is the rarest example of fabulous people doing great work for nothing but the right reasons. And my enthusiasm for ICER is boundless. You might have seen the op-ed piece that I sent, that I had published last week in the New Hampshire Bulletin. And in that, my praise of the annual report that Mr. Williamson prepared was even more effusive than Representative Mertens is or was a few minutes ago. Why? Because I see a lot of government reports as a state employee, and I seldom see anything that is so forthright and informative as this annual report is. And again, I say that as a CF dad who happened to notice that the most expensive drug on your list is the drug that my daughter takes as a cystic fibrosis patient. But you don't have to be a CF dad to care about a report like this that names names and identifies problems and provides hard data. Because the hardest thing about being a person like me who cares about drug prices is the total inability to get data that really is informative. Like, for me to figure out like what drugs really cost, that information isn't accessible to to me as a member of the public and as somebody who takes prescription drugs and whose loved ones depend on prescription drugs. That's very frustrating. So it's extremely gratifying to see a report that both diagnoses problems and gives hard data to illustrate for the public exactly what the problem is. A drug that has a list price of $300,000, when a fair price would be easily less than a third of that, that is the problem, in my view. I am concerned, there's a lot of talk about stakeholders. That word gets used a lot, has already been used a bunch here. And I guess my critique of any public process that I get involved in that uses the word stakeholders is that it too easily becomes a substitute, although not the equivalent, for the word public, right? I mean, the potential problem with, say, your advisory board is that there's really nobody on the advisory board who represents people like me, people who earn a salary as a state employee, depend on the prescription drug benefits the state is able to provide, and cares about making sure those benefits can be as good as possible. And, people who make their living in one of the industries that's related to the world of prescription drugs, I don't think those people really qualify, although you need their expertise. They don't qualify as ultimate stakeholders the way consumers do. And I would urge you to find a way, therefore, to make sure that consumers have a voice at the PDEB. And I just want to respond a little bit to the discussion about RSA 91A I heard a few minutes ago, because in connection with my day job, I've had to chair, convene, and monitor a lot of public bodies that are subject to RSA 91A. And so here's my little sermonette about RSA 91A. The most important thing to do in complying with RSA 91A, and there's case law that says this, is that you really need to comply with the spirit of RSA 91A. And the spirit of RSA 91A is transparency and doing the public's business in public. So as long as you know that you are doing that, the chances that somebody is going to sneak up behind you and nail you for violating RSA 91A is low. On the other hand, if you're deliberately trying to circumvent the transparency principles by whatever trick that you think you might devise, then you're subjecting yourself to real trouble. So I really think keeping an eye on whether you're compliant with the spirit of the statute is the most important thing, because it is easy to get caught up in the technicalities of RSA 91A and allow it to impede your ability to do business, right? Like, I really do think that the First Amendment, which gives people a constitutional right to peaceably assemble, like, it hasn't been suspended just because you happen to have some connection to a public body, right? Like, two people can have conversations with each other, three people can have conversations with each other. What you don't want to do is gather quorums together informally without warning them publicly. You don't want to use email as a substitute for deliberations that should occur in public. You never want to decide anything other than at a public meeting that has been warned, so people like me can come and watch and listen to you make decisions. But I really think you can get too caught up in this idea that you can't really exchange information with each other between meetings. You can't gather insights. You can't do research. I think as long as you're not deciding anything, you can pretty much do whatever you want and not violate RSA 91A. That's my take. And I think it's a little more flexible than the advice you're going to get from the Attorney General's office. So, but just remember, even the people at the Attorney General's office are fallible human beings. So that's my sermonette about RSA 91A. The other thing I would say, since the insurance department is over at the Walker Building, which is a nice building, Commissioner Arlinghouse has made very clear to all of us state employees that all of the meeting rooms in state government, including this one, are shared property, right? Like, even though we're here at a DHHS building, this room doesn't belong to the DHHS. It belongs to state government generally. So you are supposed to be able to ask, say, the Department of Education, which happens to have a very big and pleasant meeting room right behind my office at the Walker Building. You're supposed to be able to ask the Department of Education to borrow their room. And if it is available, they're supposed to say yes. Same thing with the Public Utilities Commission hearing room. I don't want to tell you the answer you're going to get if you ask to use that room. Technically, it's supposed to be available. And the insurance department, I don't know what they have back there because I've never actually used it back.
They
They may have some space available. So in other words, this is an important body and you should have the rooms and facilities you need to conduct your meetings. And you shouldn't be shy about asking for them. My office, which is also in the Walker Building, just has a conference table, which you'd be welcome to borrow, but I don't think it would help. Anyway, I just want to say that I'm committed to engaging with the PDAB as a member of the public because it really matters to people like me and my family. And so I will be here as much as I can. I want to thank you for your good work too. I really appreciate everything that you all are doing.
Just a quick question for Don. I think that's a great point about having a member of the public who is covered by a public payer. That's the ultimate stakeholder on the advisory council. Is that what you're talking about?
Yes. But it's so hard, right? Because like, if you look at me, for example, I mean, this is an obsession of mine. It walked up behind me one day, tapped me on the shoulder and said, turn around and follow. It's nothing I ever thought I'd be doing myself, but I'm empowered, right? Like I'm an appointed official of state government. So I don't even know that I qualify as a true representative of the people. I mean, ideally, you would find somebody who operates in state government at a much lower level than I do and who really is, very, very dependent on whatever benefits the state provide. My daughter Rose, like she has 3 different insurance plans available to her now because she has a day job working in state government in a neighboring state. She has 2 parents who are both working professionals. So she's never going to be out on the street not getting the drugs that she needs, or at least I don't think she will. But there are people who really have to worry about that kind of thing.
Right. So what I'm thinking of is the 2 bills that we have going through, maybe working with having the legislators work on possibly adding another person to the advisory council. We do that really commonly on commissions and committees and things where we have someone who is a potentially directly impacted by anything that comes out of that body sitting on the commission. So I think it's a great idea to.
I think most of the boards that I've ever served on, we've always had public members.
Yes, my office, the Office of the
Yes.
Consumer Advocate, we have a statutory advisory board. It plays a really important role. There's nobody involved in public utilities on that board at all. It's all members of the public.
Yeah. It's a good point. Thank you.
Or up there.
Anybody on the screen?
On the screen, anybody else who wants to public comments? I see there's 19 people in the audience via Teams remotely. Does anyone have a comment they'd like to share with the board? Hearing none, then I'll close public comments. Thank you, by the way, for that. Well, at this point in time, we're going to reconvene on January
January 27th.
27th.
9:30, 12, well, yeah, tentatively 9:30, 12:30.
And you'll look for a new location and so forth.
Yeah.
Okay.
Now that I know it can go to anybody for this room, we need to find the nicest room.
Question for the advisory council. There are ones that are required statutorily. Is there any limitation on why you can't add people to it? Is that really not that they're an advisory capacity? Do we have to go through the legislative process, or do we at that point in time informally or basically ask people to join the advisory council? They don't really take a vote. If a person comes in who's not an official member of the advisory council, they would take a vote. That person obviously would not have a vote.
I think we would need to establish rules around that. I don't think we'd want just.
I think that protecting that position would be optimal by having the statute.
We have a convention representative, but I don't think it's as. It's Tyler Brannon is the consumer representative as appointed by the governor. But we do have another advisory council position open. Since Governor Sununu didn't appoint anybody. So maybe that
That would be.
that
the-
person
probably the
could
best
be
position.
somebody that's representative of state, plan,
Right,
or that, but I also don't know,
somebody who's covered by. the-
yeah, I also don't know about finding, I don't know, but just HIPAA, finding somebody who wants to talk about their medical conditions or the drugs they take.
Well, they wouldn't have to. They could just be giving their opinion
Sure.
as somebody who is covered. But I think it provides a unique perspective.
Or someone like Dawn.
Right.
You know, just, it's someone coming at it from a different point of view is looking at, which I think the voice of the patient is critical here.
It's the voice of the beneficiary.
Beneficiary. And at that point in time, is trying to find out what's the impact on the beneficiary, because if we're doing certain things, we're talking about making drugs affordable. We talked about this before, affordable to whom? Because you have the affordability to the employer, but you also have affordability to the beneficiary, in this case, the patient. And I think both of those have to be taken into consideration. That is sort of a tension in there. But if we don't have a counterweight on both sides of it, we're losing a very important voice.
And it's not just affordability, it's
Availability. Yeah,
Well, if I might interrupt,
sure, please.
if you want to look at a great example of that exact tension, look at the deliberations at the Colorado PDAB over the alleged affordability of the CF medication Trikafta. And I mention that because my daughter went and testified and basically said a $300,000 a year medication is not affordable. But then what a lot of people in the CF community in Colorado said was, well, we have access to the drug and the manufacturer is giving us a copay assistance program. So we think the drug is totally affordable. We thought that was an absurd result in Colorado. But the people who argued against us or against Rose there, they had a point, like they're getting the drug. And to them, it really is affordable. So there's really two flavors of affordability, and they're both important.
Yeah.
So at this point in time, it's 11:15. If I don't have any other public comments, then I will officially adjourn the meeting at 11:15. We'll reconvene on January 27th.
All right, thank you, everybody.
9:30.
9:30 to 12:30.